Welcome to our radial cocktail hour. My name is Kelsey Miller, and I'm the product manager for the Sublime Radial Access portfolio. Extremely excited to have Dr. Sayfo and Dr. Pradeep Nair here with us today. So just to give quick introductions, because I know everybody loves that. Dr. Sayfo is an interventional cardiologist at Baylor Scott and White Legacy Heart Center in Plano, Texas, and basically sees radial-first vascular interventions as a major opportunity to improve patient care while optimizing hospital processes and really kind of the cost containment component of it. And then we also have Dr. Pradeep Nair here, who's an interventional cardiologist at the Cardiovascular Institute of the South in Houma, Louisiana. Dr. Nair serves as the director of the vein program at the Cardiovascular Institute of the South, and he's also vice chairman of the annual New Cardiovascular Horizons meeting in New Orleans every year. So everybody that knows Dr. Nair can attest to the fact that he's a master when it comes to radial interventions to the periphery, and just as an extremely talented educator. So extremely happy to have everybody here tonight, and we'll turn it over. Again, open forum, so if you have any questions about cases, about anything about kind of a radial perspective platform, setting up your clinic or anything like that, come off the mute button. You can also raise your hand if you want, or else put it into the chat function, and we'll make sure that we get your answers addressed, or your questions addressed. So with that, Dr. Sayfo, Dr. Nair, I'll hand it over to you guys.
Awesome. Thank you, Kelsey, for setting this one up. And again, as Kelsey said, we're going to make it as interactive as possible. And Dr. Nair has an amazing experience with the radial to peripheral and, of course, endovascular therapy in general. And we'll try to do it is, back and forth discussing different experiences and different way of making radial to peripheral program a success. So this is slide we always have to pass, which is our disclosure. Also, I have to hold it for 3 seconds and pass through. All right, so I think the radial to intervention in general started something around 15 years ago with the radial to coronary, and people on the webinar today who've been practicing for that long, they remember that transition. And you've seen early on where you have a lot of people who were against it because femoral access to coronary intervention has been, an easy way to do it. And look at now, 15 years later, where we are. We have all this kind of, if you don't do radial, you really you're left behind. And if you look at 2018, what we had, and this is specifically for radial to peripheral, where we are now in radial to peripheral is where we were 15 years ago in the radial to coronary. But in 2018, this is the equipment that we had. And Dr. Nair, when did you start doing radial to peripheral? Was that in 2018, a little bit sooner than that?
We really started delving into that space probably around the time, I think it was closer to 2015, 16, in that range. We had the first radial sheaths came out, not that long after. We knew going into this that radial was an access site that was, it's imperative for all of us to utilize. I mean, we see patients are more comfortable with it, but, and then being in the interventional cardiology realm, you do a radial case pretty much for all of our patients now. And when you're sticking the groin, they're asking you why. And so it was a natural transition for us. But I will say that there's been a lot of learning curve, but we really started from the get-go around 2015-ish.
And I assume also prior to that, you've done some upper extremity accesses like brachial or axillary. Can you speak about why would you not use brachial? I mean, what's the big deal? I mean, why would all this fuss about radial access in the first place? I mean, brachial access, it's a big vessel. You can put same sheet that you had, you can put a 95 sheet all the way down and do your intervention. Why not just stick with the brachial that worked?
It's one of the access sites that we had to use in certain scenarios when, for example, the femoral arteries were hostile, the access sites were not possible, or they had axillofem bypass grafts and so forth. We would stick the brachial. Now, one of the issues with brachial access is the fact that, we could use traditional sheaths, 6 French, 7 French sometimes, and we can get the procedure done. You know, we use ultrasound guidance, get an anterior wall puncture, but even the best anterior wall puncture is hard to sometimes close in a brachial access site. Hemostasis is the issue. Closure was the issue. You could have a great case that had transpired, and then you're dealing with an artery that is in a location that is not always easily compressible. It depends on anatomically where the patient's brachial artery is traversing. And I will say that, you know, one of the issues with brachial access is that after it's done, I mean, there are a lot of nerve-related issues that can happen from damage, but those weren't the main issues that we saw. We saw a lot of, you know, issues with pseudoaneurysms, late bleeding. When they go to the floor, they inadvertently bend their arm, and then they have a bleed that pops. And, you know, when radial sheaths came into fruition and were a possibility, that really revolutionized and changed the way we approach access in the upper extremity. So I will tell you, I still use brachial access sparingly if I need to, but radial access will always be my go-to now, unless there's a reason why I can't use it.
Yeah, I mean, I think definitely the brachial access, it's a possibility. It's an access. Axillary access is the same, but closing those sites are just a little bit harder. And you know, the whole purpose of going from femoral to radial is to minimize the site access complication. And you know, with the pseudoaneurysm, the bleed, and require sometimes even surgical intervention to get those treated. I think that's where radial kind of picked up. So, you know, this is 2018, what we had at that time. And we started, you know, dabbling in our institution with the radial, maybe 2018, 2019. And we had a lot of limitation. We only went radial to peripheral in very specific cases. I mean, now this is what we have. And I think this is, you know, this is a lot of extra equipment that added to the toolkit that helped kind of advancing the therapy, and the complexity of the cases that we treated in the first couple of years versus the last, you know, I would say 12 months has changed quite a bit. Can you speak about, among all of the one that in green, what would you think is the two most important technology that you think has changed the way you approach those patients?
It starts with the sheath. The sheath has really changed the way we approach these patients, because previously, you know, we had slender type sheaths. We had, you know, sheaths that were radial friendly from the interventional cardiology world, but they weren't long enough. And now I think having that ability to have a sheath that provides the adequate support for performing these procedures was the number one facet that was of value. Now, I think this, you know, I'm going to jump ahead with what I think is next and most important, and that's just my own personal feeling. But the wires, I think, are fine. They're adequate right now, but there's still a long way to go in our wire technology, in my opinion, from the radial aspect. And what I'm trying to get at is we still have so many different wire choices that we can utilize, CTO wires for crossing infrainguinal or any peripheral arterial occlusive disease, that still to this day, I mean, we can use it for radial procedures, but there's more, you know, they're not long enough at times, or we may have some issues with wire and catheter exchanges. So I think wire technology can be improved. I think the next issue that was of value was the balloons. And so the balloons have been extremely valuable, because now we can actually reach the foot from the radial artery. And that's been a progression over time. I mean, before we couldn't even reach the foot. We could reach the SFA popliteal segment, maybe if we're lucky, the proximal tibials if we needed to. But now, you know, Sameh, as well as I do, when we do these peripheral interventions, there can be a reason why you need to chase something distally. And now we have the ability to do that with the balloon. So I think that's been the second most important advancement. And, you know, you can look at number 3 or number 4. I mean, as far as atherectomy is concerned, I think it's been a great achievement to have the ability to perform atherectomy for some lesions, such as calcified lesions with orbital atherectomy. But in my practice, you know, we still treat stents. I would like to treat in-stent restenosis, and I think having the laser available in the future will be a great benefit. But I mean, I can go on. Crossing catheters, all of these things that are being developed are important, but I think it starts with the sheath, and I think the second most important advancement is the balloon. So we got those two, and now we just need to kind of fill in the gaps.
Definitely, I think that the sheath to get you all the way down and give you a lot of support where you can cross with those sheath and take pictures and support the intervention. I think the DCB that we just recently got has changed the way we practice. You know, initially when we practice, we used to I used to avoid young patients to go radial because I don't want to end up either this PTA or end up with a stent where I don't have to stent, and you get limited on the DCB at that time. And I think now having 200 centimeter DCB, I think has changed the type of patient that we treat and maybe expanded the type of patient. I think the microcatheter is a game changer. I mean, till recently, we only had one microcatheter, that the 200 microcatheter, that was just not good. And I think now with, you know, the Surmotic bringing the 014, 018, and 035 microcatheter, that helps a lot. I mean, not only in this field, but also when we do, you know, even from femoral access, when you do artery construction and below the knee intervention. I think this is, you know, this is a list of possible things that needs to be advanced, but we have a lot of things. I think that, you know, IVL from radial is a necessity at this point. Other equipment that we use in below the knee that we don't have yet. But I think it's, I mean, just looking at the last 3 years, I think the companies who make those devices has kind of recognized that radial to peripheral is going to be the mainstream therapy in the future. Yeah, so I think microcatheter and DCB are important. I think this is number 1 or 2 for me.
Yeah, I think all of those points are excellent. And you know, from where I stand, I think the future looks bright. You know, and we're still early in this whole process, and we've gone this far. You know, so just a few. You know, we just need a few more things in the toolbox, a few more tools in the toolbox, and we're really going to be able to roll very, very quickly. You know, there's certain stent technologies that I think are more beneficial in certain lesions than others. And, you know, these are things that we're going to have to sort through over time, but it's going to be an exciting time to do that because, you know, a lot of patients can be treated from the wrist, even with the tools that we have right now.
Yeah, I mean, I think that brings up, you know, a question. I think we have a question in the Q&A. I think that's a really important question. I think this slide, you know, we can answer that question in this slide. And the question is, what's the learning curve for radial to peripheral? So from your experience, what do you think, how many cases that you recommend before you start tackling really complicated ones? And number 2, let's say you're doing more than 80%. Let's say you're doing 80% of the cases radial. What are the cases that you still go femoral? So maybe this is a question for you.
No. So the first question on the learning curve really depends on what your experience and background up to that point would be. You know, if you're doing in an interventional radiologist, cardiologist, or surgeon who does a lot of radial procedures to begin with, and you're familiar and comfortable getting radial access, using ultrasound guided access is something that I really strongly advocate. That's one big hurdle that's passed. And then the second big hurdle is what's your background in peripheral intervention, right? So if you've been doing a lot of peripheral intervention to date, you know, and you know how to potentially get out of trouble in certain situations and know what types of lesions you're dealing with, to understand plaque morphology, to understand what type of strategy you'll be employing, then, you know, I think the learning curve is very quick. Right. But if you're early in the game of learning peripheral intervention and you're just kind of starting, I think you really should have that mentorship and talk to others and come to conferences, go to courses and learn from others, mentors to really get comfortable dealing with all sorts of different types of lesions. Now, if it's just a straight, you know, focal lesion, which you and I rarely treat, you know, in our labs, then I would say it's not that difficult, right? You go from the radial artery, you balloon it, and if you need to, because of whatever dissection or some reason, you can stent it. It's easy, right? I mean, that's not a major issue. But when you have a long CTO or a very complex calcified lesion, you got to think through that a little bit better, or more thoughtfully before you start jumping into it. So that's kind of like the long-winded answer to that question. And what was the second question? Oh, when do I choose radial over femoral? So
femoral over radial. Like when would
femoral
you
over radial?
when
Yeah,
would you still choose femoral?
Yeah, so that goes on to, that's kind of a tailed on to my first answer, which is I think through what I'm dealing with. So I have some preoperative imaging, I have some sort of ultrasound scan. I'm not going into a case just, you know, without having some sort of background information of the patient's risks and so forth. And so if I see, for example, dense calcification, severe SFA disease, CTO, I will go femoral because that's the only option I have. If it's a case where you need IVL, you're going to go femoral at this point in time for most cases. Some, you know, I think that's something you consider. And if I have below the ankle disease, I'm doing some sort of limb salvage work on somebody who has like calcium everywhere below the knee, I may go antegrade access. So I'm comfortable doing whatever access is necessary to get the job done. But what I will say is that a lot of the job today, that the bread and butter that we're doing today, can be done from the wrist, and that's something that we see in the lab. But you have to have some prep work done before you just jump into a case. Is my feeling.
Definitely, I think we'll talk more about some of the tricks when you try to do your cases, and we'll try to answer this question. And I think the learning curve really vary between operators, but I think planning ahead of time and what are you treating is important. I think getting the right imaging is important. For example, initially CTO, we tackled CTO from the get-go. We had some challenges and we had a learning curve. So now for all of our CTOs that we go radial with the pedal prepped. So our staff know that automatically. So they prep the pedal from the get-go. This way, halfway in the case, if I need to go pedal at the same time, which doesn't change. I mean, that's a lot of operators who go femoral does the same thing. I think one of the things that for we still go femoral if our iliac size is larger than what we have available from the radial. There are different companies that have different sizes, and if you have a large iliac artery that require bigger stent, and of course, you know, certain cases that you feel like safety-wise that you have to have some kind of a femoral access or a larger sheet. So anytime you need to use a 7 French or 8 French sheet for, let's say, you know, LVL, L6, or you need to use certain atherectomies that require 7 French, or certain stent that require 7 French, I think it's very reasonable to do a femoral access.
I agree 100% with those comments because, and also we also have a femoral artery prep in the event that we need it for whatever reason during the case, if it's accessible. Some of these cases not accessible, and pedal is ready to go too. So I mean, we have to, you know, that's another area of comfort that you should become, I think, as on the learning curve, understanding pedal access for some of these cases, because you can get yourself out of trouble, and you could also cross a lot of CTOs that way too with the radial pedal approach.
Definitely, and we're going to talk about a couple of slides. This slide I just added on to the slide to basically that maybe that can help answering that question. I call the rule of 4. You need to know your equipment, and we can discuss one at a time. You need to know your team, you need to know your skills, and you really need to know your patients. So equipment-wise, I think we've already discussed majority what we talk about, what we have available, but it's really important for someone not to tackle a peripheral via radial without having radial equipment. You can't just use what you have from the femoral in tackling anything below common femoral, you know, SFA, popliteal below the knee. So because the lengths, and also that, you know, it's important to when you plan for something like this for the physician audience, is to partner up with a company that can provide you with that kind of equipment. So figure out what equipment you need, and I think, you know, what we talk about, the basic equipment that you need, you'll need a long sheet, and I'll think the 5 French sheet has personally helped me in a couple of cases where the radial artery was very small in small ladies, and of course you need a long balloon, a long shaft balloon, and a long shaft stent. I think that's the 3 minimum requirement for you to tackle a radial to peripheral case. But I think there's other, as we said, as you know, Dr. Nair mentioned, the microcatheter, the long wire that we still, fortunately, we don't have a lot of them. DCB, atherectomy, which is basically right now only CSI has a long one that's a 180 and 200. And of course, there's more equipment coming. So let's talk about knowing your team. So how did you approach, you know, your team who's been doing this? You guys are a very, very busy center. You guys have been doing this for decades of doing femoral cases. How did you approach your team on doing those radial to peripheral? Have you had sit down with some education, or just doing the cases and answer the question? What's the best? What do you think the best way for the physician audience to kind of approach their team?
It's for our lab specifically. I mean, the main point was that you know, busy interventional cardiology practice as well. We're doing already radial, and one of our attending physicians was a proponent of left radial from the get-go. He felt that the catheters sat more naturally in that scenario. So left radial was a approach that we've already been incorporating into the lab. So it was kind of seamless for us to say, hey, we're just going to continue to do the procedure left radial. And, you know, we already did a lot of interventional, you know, peripheral vascular work. So it's basically a scenario where initially you just have to have one or two team players that are ready to try it out and see how it goes. And they have to trust your skill level and understand, you know, it's just a trust level between the staff and the physician. And I will tell you this is, so initially, I will tell you the learning curve for us was pretty quick, right? When we got the equipment, we know. And if we ever encountered a case where it was maybe a little bit challenging as far as crossing, we, like you said earlier, we would find another alternative access route to complete it, or use it as an adjunctive way of treating it. But I will say that if you talk to our staff now, okay, I'm talking about maybe if you talk to our staff back in 2015 or 2016, and you talk to our staff now, probably around 2017, 2018, if they knew we were having a radial case, they were 100% on board with that. Primarily, a lot of them were happy with that because there's no groin hold, there's no bleeding afterward. It's just basically a TR band or some sort of like radial closure device on the wrist. It was extremely easy for them. The patients were sitting up after the procedure. We weren't getting called about a groin bleed, and our patients were getting taken care of very well. So if you ask our staff now, it is quite honestly the preferred modality if they had a choice. And in our outpatient lab, we're able to treat a lot of more patients now because the patients are able to, they don't have to sit in bed and stay in bed as long as they used to in the past. And they're able to sit up right after the procedure. It's just been streamlined tremendously. It's beneficial for the physician. It's beneficial for the staff. And most importantly, it's beneficial, in my opinion, for the patients. And safety for our patients is the number1 priority.
Oh, definitely. I think we have the same thing. Our staff has a lot of experience and has done a phenomenal work adopting this and adopting other technology. And I think just what I would recommend is just have a plan. We'll talk about right radial versus left radial, and I'll tell you, maybe I'm one of the few radial interventionists for the peripheral who does right radial in 99% of my cases. But I think one thing you need to teach your staff is if you're someone who going to do left radial, you have to have the right setup. So we've had a couple of left radial when we did, and I think I've seen it on some of your live cases. You guys have a very nice setup where the arm is extended. You have the table, 90 degrees of the patient, and basically you're just basically doing your case on that side. And you have the right setup where you can see the screen. We've had a couple of cases where we cross the left arm to the left groin, and we just still work in the same spot. And I personally like the right radial just because I don't change anything. Nothing changed for the staff. The hardest thing about the right radial will be, and again, that's what I said for your team needs to know how you work. And if you're someone with left radial always, I think that have to have this setup built. For the right radial, I think you just need to have some kind of a skills to cross that brachiocephalic to the descending aorta, because sometimes can be challenging, and there's a couple of tricks we're going to talk about. But you know, I think most of the cath lab staff, when you understand why you're doing this, I think that'll become you know, for them, it just, they've done it for the coronary. You just need to know why you're doing it. And I think explaining length of stay, patient can go home the same day. If it's bleed, it's not a big deal. Just hold pressure. It's the easiest thing to hold to control comparing to femoral, and rarely you have a major complication from it. I think we talk about the skills, talk about the patient. I wanna make sure we go through the cases. But one comment about subclavian, someone asked subclavian. Do you do your subclavian from the radial, or do you go from the femoral?
Subclavian stenting?
Like stenosis stenting, yes.
Oh yeah. Nowadays I go from the radial to stent. You know, I mean, the only time I go from an alternate access point is if it's one of those flush occlusions, and you know, you can look at the plaque morphology, and if it's more suitable to cross from the femoral approach, sometimes you go subintimal if you come from above it. So but most of the time, yeah, I'm going to start radial and then go from there. It's so much easier.
Definitely. I think in using IVUS, the only difficulty is taking the right picture and able to get where the ostium is. But I think using IVUS can really know exactly where you want to land it.
Yeah.
Because from the femoral, majority of the time what ended up happening, you're like 4 or 5 millimeter in the aorta, and become harder for you to recross in the future. So this is the left radial versus right radial. So my understanding, you're a left radial mainly. That's your approach.
No, I'm an equal opportunity radialist. I mean, whatever is the better radial artery, you know, whichever. If I see a radial and ulnar in one hand and only a radial in the other hand, I'll pick the one with the 2 vessels. You know, I think the main key point, take-home point, is that a lot of the distance issues that we were facing before, like the 10 cm maybe loss going right radial, is a moot point now, because we have longer balloons now, and devices are able to get us down to where they need to go. So I personally would prefer right radial. I mean, if you know, because it's more natural for me. I'm sitting there and we have a big monitor that I can see much better than as compared to the left radial, but it doesn't matter to me either way.
I think it's a good point. You know, I think ultrasound guided radial access for radial to peripheral, I think, is important. Especially, as you said, because those patients are usually vasculopath and they have a lot of procedures done before. So you want to make sure you have a radial artery occlusion, and then you can't use the ulnar, so you have to go to the other side. So I think ultrasounding those patients is much easier. Also, sizing that radial artery can be helpful to decide if you're going to go with the 6 French sheath versus the 5 French sheath to prevent any, you know, arterial spasm. But for us, when we do the right radial, is we use a JR4 125 5 French catheter, and we're able to cross from the brachiocephalic. And unfortunately, I mean, it's funny. We always joke that if you go right radial for the peripheral, your wire always going to go to the heart, and if you're trying to do a right coronary, you get right. We try to do radial to coronary, always go to descending aorta. But I think crossing is not a big deal. I think JR4 125 5 French, it's really easy to maneuver, and you can use either the J wire or Benson. You can use a glide wire just to go over the arch. The other trick you can do is, if that doesn't work because of the anatomy, you can use actually a pigtail. And when you push the wire through the pigtail, just the pigtail opening, it will give you access to that arch. Do you have any other?
That's what I use. I typically use a pigtail catheter. And I always use, when I navigate up from the radial artery sheath, a J type wire, floppy J, like a baby J type of wire, because you sometimes never know if it goes into a small, if you get an angled wire, it goes into a small branch. Sometimes you will not know. It would be less chance of trauma going with an angle. That's just what we've been doing traditionally.
Definitely. So we always go with a J wire. We less than maybe 2% of the time we had to use a glide wire at the arch area, not proximal to that, not in the arm itself, as you said, because using glide wire from the get-go, you can get you to a small branches, end up having a hematoma in the arm, and then the whole case kind of ruined before you started. So we're gonna go over some cases, and we try to do these cases, you know, in this kind of order. iliac occlusion, common femoral artery, simple superficial femoral artery case, or complex, and then pedal loop. And again, let me see if there's a few questions we need to answer. So when you do left radial, do you switch the table work from the left side of the patient? That's a question for you, Dr. Nair.
Well, I'm sorry, what was the question?
If you use the left radial, do you switch the table work to be from the left side of the patient? Do you move the whole table to the left side of the patient?
Yeah, so the patient's arm is like this, okay? And my table is right here, and we have another monitor that's looking straight ahead. So I'm actually, the legs are this way, and my head's facing this way, and the arm's like this. That's how we do it. That's how our setup is in the lab. And if we're doing right radial, the arm is like this, and I'm just working over here and just doing it traditionally like we normally would do for any other case. And the monitor is over on this side. So there is a diagram that's out there to show various labs room setups, and that's important to, if anybody has any question, they can always reach out to me. You know, it's already well published on various room setups, but that's how we do it. I don't put the arm like this only because it's challenging for me. I'm not the tallest guy in the world, so it's always hard to reach over and do all these other things. It's just a pain.
Yeah, definitely. I think that's some of our operators do left radial for coronary, and usually they like to go left. If they are the to go left radial kind of situation, they work from that side. And when we work from the left radial, it's much easier to switch the table. But as you said, a lot of rooms are not set up for a radial setup for the left groin or the left radial axis to begin with. So you end up working on a small monitors instead of the big monitor you have on your traditional axis. And I think, you know, it's a question about how to mitigate the radial loop and how do you go through type 3 arch. I think that's I think similar to what we do in the coronary. There's really nothing.
Right.
You take, if you push the J wire and the J wire doesn't go, make sure you take a picture, make sure you know where your wire is going. You can mitigate it. There's a different way. There's something called a BAT technique. You can also put a sort of, you know, Benson wire, sometimes go through that loop. You can use a coronary wire, but I would not recommend then follow with either a glide catheter or a tiger catheter, and then when you get across the loop, pull it back counterclock. That will straighten the loop, and you can put a J wire or stiff wire and you switch to it. There's a lot of technique for the radial loop.
And one
other comment?
The only point I would make about radial loops is getting, you know, you can still do the procedure, no problem with these loops. The only caveat is that when you're done with the procedure, I recommend putting a wire back in and the dilator in so that you get more straightening when you come out of the vessel. So just remember, don't just pull the sheath out, just put the dilator and wire in, and it'll come out much, much smoother.
So in our lab, we try to do that in almost 100% of the cases for multiple reasons. That's one of them. Two, we like to make sure that we're not coming across the arch back. Again, we'll go right radial. So the arch and the brachiocephalic with that taper, so to try to minimize possible risk of stroke. And then the two ways of closing that radial sheath is either you pull everything out, you know, you put a dilator in, you put a wire in, you pull it all the way out with your staff ready to put your closure device, either fast band, TR band, whatever band you guys have. The other way we've done it is where you pull the catheter all the way to basically distal to the brachiocephalic or maybe in the axillary. We switch to an O1H wire, pull the sheath out, put our short sheath in, the one that we already had in the beginning. But just to remember, you need to have an 018 or 104 wire. Otherwise, you can use it on 035 because it's a radial sheath. And then your staff will take care of the rest if you need to keep going. Good question so far. So we're going to go through a couple of cases. So iliac occlusions. This is a 67-year-old female, history of diabetes, hypertension, hyperlipidemia. She came with bilateral claudication, and this is her ABI. If you notice, her ABI is 0.23 on the right, 0.37 on the left. She had an attempt for bilateral femoral approach, and they tried to use a glide wire from the get-go, ended up with a dissection. The dissection extended all the way to the distal aorta. and they could not re-enter in the bifurcation level. So the question is, what do you do? Do you reattempt femoral access, with or without utilization of free crossing device, open surgery for aortic bifem bypass, treat with medical therapy and hope that patient doesn't have any ulcer or resting pain, or others? Of course, we're biased. We're talking about radial access. So
I think this is going to be a bunch of others. Let's go for others.
So the reason I put those answers, because number one and number two are not wrong answers. It depends on the clinical scenario for the patient and, of course, who's treating this patient. So if you're going to try to do an occluded iliac, from the femoral axis, you really need to have recrossing devices available, because those are really complex one. And I would say the number one thing that I would say just be careful with is not to re-enter too high in the aorta and maybe, end up with a bigger issue. Aortic bifem bypass, it's not a simple procedure. It has its own risk. So 67-year-old patient, this is not a very high risk patient. Just treating medication and hoping nothing happened, I think that's just not how we work, how we treat patients these days. This is what we have, and you see on the left side, it's completely occluded right iliac, and the left has some kind of channel through it. Single axis radial, across the right side. This is IVL therapy, and then a balloon expanded stent. What we didn't show here, after the IVL, we took picture, and actually the lesion did not extend to the aorta at all. There was a nice nub on both sides. So what we did here is we stented each one of those from a single axis, and then this is your final result, where you kind of see a kissing, we end up with a single axis kissing balloon there. So a couple of questions here that comes up is, this is the final result. This has actually been 3 years ago, so no restenosis so far. What's the limitation on balloon expanded stent in this situation? What do you guys do, and what product do you have available?
So from the radial access site, if you have densely calcified vessels and for whatever reason you are concerned that it could rupture and you want to use a covered balloon expandable stent, that could be a limitation. Some of these radial sheaths will only accommodate a 6 millimeter stent, right? And in the shortest of those. But it's less of an issue with a lot of the balloon, the nitinol balloon expandable regular stents, so like uncovered stents. You can, I believe, if I recall, 7 millimeters you can go up to with those types of stents. And so one of the most important thing I think you have to understand is the length of your sheath and the shaft length of your stent, right? I've made the mistake before. I will admit it. I pulled out, I had a short shaft stent length, and I had a long sheath in, and you just have to eat it, so that's a learning curve for the staff, is always confirm your lengths before you open them up. Now, I think that's a great demonstration of how you can do radial procedures, but in these scenarios, especially with all the calcification, I would, definitely have your groins prepped in the event that there's a perforation, and always be ready to balloon tamponade. You have to be ready for those kind of things when you do these types of procedures. But iliac disease, especially, you showed a great example of IVL, can actually, I think can safely be done from a radial approach, but definitely have backup plans. Don't, whenever you're doing these things, in order to mitigate any kind of risks that could occur.
Yeah, definitely. So a couple of comments about this. So the largest stent, a balloon expanded stent that you can go through, a 6 French radial, it's actually 9 by 19.
9 millimeter. Yeah.
9 by 19. So 8 should be fine. But if you have someone with a 10, 12, just don't put an 8, because that's just not the right thing for the patient. The other thing is sometimes the radial helps you as adjunctive access. So it's much easier to cross from the top than crossing retrograde, because you can end up sometimes with a retrograde in a dissection before even you start, just from your microcatheter, microwire. So sometimes it's helped to go from above, and I don't have that case. I have a couple of cases like that where you go from above, You cross through it, you can snare the wire, pull it from the bottom if you have to use a larger stent, or you need to do a cover stent. So that's number one. So number two, the argument that actually I presented a couple of those things in the national meeting, and then some of the experienced operators had that question is, what if you have perforation? So I think it's actually, if you think about it logically, it's the safest thing to happen if you have a perforation from a radial, as long as, again, I'm gonna reiterate what Dr. Nair said, you have your femoral access ready. You don't have to access it, but what happens if you have a perforation there? You just inflate the balloon and you tamponade it, and then you have all the time to get access, 8 French groin access, and you have your VBX, and you just cover it. Where in reality, if you go femoral and you perforate, you have your balloon inflated, but most of the time you have 6 French or sheath, so you have to upgrade either by where the patient is bleeding, or you have to get contralateral access, try to go up and over and try to manage that. So that's my theory. I think, nothing I mean, one of the worst complications that ever happen is an iliac perforation. And someone who any operator who's going to do a lot of work, they're going to have one in their lifetime. So whenever you do iliac, you got to be prepared. Make sure you have the cover stents available, or at least your staff know where they are. Make sure you have an 8 French close by or sometime on deck, and make sure that you have a strategy for bailout, because patient can bleed, and they can bleed really quickly.
And I'll make one more comment on this. So, when you're starting out, I think this is a great case of showing bilateral iliac disease treated with one access site. But I don't think it's wrong. I mean, the occlusion was crossed with the radial to get left femoral access and cross the non-occlusive disease and treat it that way. I do that from time to time whenever I want to have kissing stents married to each other right from the get-go. So I think that's an option. And also crossing from the above, you made a great point of that. We've crossed a lot of aortic occlusions from above, and I used to access from the brachial to do that. Now I will universally stick the radial to cross aortic occlusions, and I will have femoral access for that. But that's a whole nother type of case. But I will Definitely. Say that this just shows that you can do it from the radial, and I think it's.
And if you want to torture yourself very well, you can get bilateral radial access and do it. But
you can.
We have a few cases that was done, but I think that's just require a very patient operator and very patient staff, because the setup become a little bit more difficult. But we've done bilateral radial CTO, so I think that can be done. This is a second case, 65-year-old female, history of pelvic radiation and uterus cancer. She actually used to live in a different state. She had a claudication Rutherford 3. And she had an abnormal ABI. CTA showed bilateral severe common femoral stenosis. And in the other stage, she ended up getting what's called the gold standard, which is a common femoral endarterectomy. And unfortunately, that ended up with an infection and lymphedema, required IV antibiotic for 6 months, and lymphedema lasted almost a year before was able to be managed. She moved to Texas, and she basically still have claudication on the left leg, and she asked for a non-surgical intervention. So I thought this is a good point to kind of look at the data that was presented. Again, this is the surgical papers, both surgical papers, one from 2008 and one 2015. And the one at the bottom is actually from the Journal of Vascular Surgery, from the Society of Vascular Surgery. And they looked at basically all common femoral surgeries that in that trial, and to look at the complication. And this is the complication, and I really would like everybody in the audience to look at this, because common femoral artery surgery from a surgical perspective is not complicated. But if you look at it, takes time, which is fine. Blood transfusion more than 4 units, around 3%, again, not a big deal. But look at post-operative complication. You have close to 3 to 4% mortality from this simple procedure. 10% go back to the operating room for either bleed or infection or debridement. Wound complication is 8%. That's big. Superficial infection, deep wound infection, and wound dehiscence, they are between 1 to 6%. So this is not a benign intervention. And I think this is something that's becoming more and more now with the technology that we have available to treat common femoral artery stenosis. Become question is, should you send patient for common femoral artery endarterectomy, no matter what their risk factors are? So anyway, I'm going to show a case. That lady, I always wanted to point that out because this is something from our colleagues and partners in the Society of Vascular Surgery. And I think now with the technology we have, we're changing the pathway. So this is the angiogram. That's transradial angiogram. And I was trying to with our fellows, and our endovascular fellow knows this question by heart now. It's what's the most important artery if below the aortic bifurcation, and it's the profunda. So you got to protect the profunda. And you see in this patient, heavily calcified, 99% common femoral artery stenosis with compromised profunda. So again, nothing wrong by sending that patient to surgery, but this patient already showed you that she had complication. So the approach in this patient, transradial 6 French sheath, 120, 2 wires, 014 wires in both. Start with the IVL of the left side, a 6.5 by 60 M5 plus. Taken out, put it back in the other wire, doing IVL to the common femoral to the SFA, and then cutting balloon to, we went back with a cutting balloon to the profunda, projective therapy, and then this is a 7 by 80 DCB. And this is your final result. Type A dissection, if any, there's no perforation. Both profunda and femoral artery and the common femoral looks widely patent with no distal embolization. So, Dr. Nair, can you comment about your practice now with the technology we have in the common femoral, maybe not related to radial to peripheral, but in general now with the L6 and the different atherectomy devices we have? What's your approach to common femoral?
So, we will treat common femoral arteries quite routinely now. I think it's the only, I do still send occasional patients to endarterectomy. I'll tell you who those are. Those are the patients where I do not feel I'm going to get a good result or an adequate luminal gain. Calcium like boulders, and you can still get a good result. I'll still treat it if I need to, with whatever modality I need to, but that's maybe the exception. The vast majority, you showed a case right here. This is really severe calcification. I'm talking about even more severe calcification than that. This is, when I look at a case like this, I think radial first. I think these cases can be treated with radial approaches very, very effectively. I think radial and common femoral arteries go hand in hand because lesions length is less of an issue. We can reach most of our devices to that target lesion. And, when I see this, the most important thing you mentioned, you treat the profunda and make sure you preserve it like gold. That's your number one and most important vessel. And you have to utilize the right modality. I think you utilize the right modality here. I think IVL makes a lot of sense here because, I think also orbital atherectomy is an option, but you would have to rewire it twice, right? You'd have to, if you're going to treat, you may have to treat into the profunda, pull the wire out, and then treat into the SFA. And that may not be something that's ideal that you would want to do. And if you have to bail out in a scenario like this, it could be an issue where you have to stick the profunda. I would stick the profunda directly if I have to, if I lose it, because that's an important vessel. But we have the tools now. And I think you showed it. We have the tools to treat this disease. This is the left main of peripheral arteries, right? This is the left main of peripheral arteries, or you could look at it down below the knee at another left main. But this is it. And I think we have to be, if I have a patient, I look to treat them radially now. I really do, instead of going even from the groin.
Because usually we know that, peripheral arterial disease, for one reason or the other, are very symmetric. So patients who have common femoral artery disease, more likely than not, have the contralateral, having some kind of disease, may not be as severe, but a lot. You want to try to avoid it. I think the most important thing with common femoral artery intervention, in addition to protecting the profunda, is IVUS, because those vessels are huge. They're big. They're not 5 millimeters. Nobody has a 4 millimeter common femoral, 5 millimeter common femoral. We underappreciate how big those are, the same way we underappreciate how big below the knee are now with the therapy we get and the use of IVUS. So if you're starting to treat common femoral and you want to compete with a surgical approach, I think IVUS is extremely important, and using the right sizing tool. Directional atherectomy works in certain cases. CSI works great. Sometimes you have to combine both. We have multiple cases we combine CSI and shockwave, IVL. But
and there's going to be other tools available now. You mentioned in the pipeline is laser, and we have to keep that in mind, because certain, there is some data now showing that it can be useful in calcific disease, in fracturing the calcium. So in that scenario, you could probably keep 2 wires in and treat, right? So there's benefits. There's benefits to keep in mind.
Definitely. And I think someone asked, how often do you use a filter for shockwave? The answer is never.
Never.
If I'm using just shockwave IVL, I don't put filter. If I'm using adjunctive therapy, a CSI plus, which is off-label use to put a filter, but I use filter for those. Laser for stent and coronary stenosis. HOC, I put a filter in almost all of my cases. Yeah. But IVL, I think that's the beauty of IVL. Looking at PAD3 trial, I mean, having 0% complication in the randomized trial, and for the observational trial to be 0.7%, that is just unheard of in the world that we live in. So yeah. I personally don't use any filter there.
And there is a the 2.0 max burr from Abbott CSI now. Something like that can really, really effectively get you luminal gain and treat common femoral arteries really well.
Yep. So I'm going to go through this one. Go ahead.
No, go ahead.
I'm going to go through this case really quickly, because this is really simple. This is going to be your bread and butter. I know, I think most of the audience have experience with peripheral intervention. This is your bread and butter. I'm going to go quickly and finish up with the last 2 cases, so we're still on time. The reason I'm showing this case is the complexity of the right brachial. I mean, J wire gets stuck there. Take pictures, figure out what's going on there. And we like Benson. It's a soft tip wire. Even with J's, you just have to kind of figure out and do it. Glide wire is not wrong, but you really got to be careful with the glide wire, because it can go places where you don't want to go. This is just showing you how crossing this with a GR4. I like GR4 catheter instead of a pigtail for one reason is this. It's just I'd be able to maneuver the catheter a little more comfortably. But pigtail, if you have a straight shot, especially if you go from the left side, works great, because you can put it in the abdominal aorta and take a picture and figure out what your anatomy is. But this case is just, again, straightforward. You have a tight sequential lesion, proximal SFA and mid SFA. This is just old-fashioned balloon angioplasty, DCB, and this is pre, and the next one is post. So really, this is, someone asked the learner curve. I would do those cases. Maybe you start, when you're going to start the first 10, 15, maybe 20 cases, just keep them simple, simple iliac, simple SFA, nothing that require a complex intervention. If there's no, Dr. Nair, do you have any comment, or do you want me to jump on the next one?
No, I agree. I mean, this is your learning curve right here.
This is a little bit more complex patient. 75-year-old male, medical history PAD, known left iliac artery and common iliac artery occlusion. Had a fem-fem bypass 10 years ago. That failed and required a redo surgery, another fem-fem 4 years ago. He started having life-limiting claudication 6 months ago and got worse on the right side, had an ABI that's bad on the right and 0.92 on the left, and had a CTA that showed occluded ostial right SFA versus what they call the distal common femoral artery, and just distal to the takeoff of the fem-fem bypass. Again, I confirmed that the left external iliac artery and common iliac artery that was occluded 10 years ago is still occluded. And this is your radial picture. So what we didn't show here is that someone has placed a right external iliac artery stent from the common femoral artery, and that was like a 7 mm stent, self-expanding stent in a vessel that was at least 12. So that gave us a lot of a challenge to be able to cross from the top just to get something through that stent. But we got a microcatheter there, and we took a picture, and you can see the fem looks great, but right below that you see basically it's an occlusion, and we see some flow from the collaterals coming through. So what we decided on this one, let's go step by step. We have a microcatheter there. Actually, this is we end up with a 120 Sublime 6 French sheet. My endovascular fellow, like a champ, she crossed with the 018 command wire, 150 support catheter, and she was able to pass nothing afterward. We couldn't pass anything through this. The wiring, she was able to find a channel that we believe that's true lumen, even though it's 100% occlusion. And what we ended up doing, we ended up using a 2.0 balloon, and then we're able to cross the support catheter, and we put our 475 Viper wire. That's the only really long 014 wire that's available, unfortunately, right now. But we needed to use it for the CSI part of it. We delivered orbital atherectomy with 1.75 burr over 180 centimeter shaft. We made sure that we crossed the distal, we crossed forward, and we did the therapy backward for one reason. It's just we want to make sure that we do not disrupt the takeoff of the fem bypass. Then we did an IVUS that showed there's an actually 80% lesion above the takeoff of that fem bypass. So now we found a blockage that's 100%. We crossed it and we treated it, and then we found something above it.
Where's your sheath park? I can't see the sheath. Where did you have your sheath park?
Very high up, somewhere in the common iliac.
Gotcha.
Maybe just at the common iliac.
Okay.
And that's a good question. You know, actually, this is a good question. So, when would you choose 120 versus 150? That's a question that I get asked all the time, and I have my own algorithm, but I'd like to hear what your algorithm is before I finish this case.
Yeah, I mean, for me, it's, you know, what am I treating? Am I treating? I go 150 if I'm treating anything from the distal Hunter's Canal below. That's how I choose. If I'm going Hunter's Canal below, I'm going 150. That's standard for me.
Or the other thing is, sometimes when you have someone who had an EVAR before, those EVAR limbs.
Yeah, that's a good point. Yeah. If you have to do some sort of navigating through a lot of tortuosity in the anatomy, but most of the time that's like the general gestalt is for me is if I'm treating it really low, I'm going thinking 150 from the get-go. And if I'm treating infrapopliteal disease, I'm probably going 5 French anyway. Yeah, that's what I've been doing.
Perfect. Yeah, I mean, I think that, you know, that one, if patient has had an EVAR before, or very tall patients, we've dealt with 6.3, 6.4 patients.
And this brings up a really good point. So just real quick, I don't want to delay, but I use a 150 catheter, like some 150 centimeter catheter, pretty much invariably, like some kind of crossing catheter. This is how I do it. Just because I shove it down the vessel as far as it goes, so I know in my head, in my brain, okay, this is as far I can go with 150 now. Now what devices can go where? So that's what I do to help me out, especially with different heights of patients. It's just a little point.
No, actually, I'm happy you mentioned this, because last time we were in the training course, and you did that live case, and you've shown that, and actually I started doing this, you know, changing my practice, because I think that's a really smart way to tell you where's the lesion is in comparison to 150, and what devices do you need to use, because sometimes a 150, for example, range will reach, or a CSI, you want to use a CSI, do you need the 200, do you need the 180? I think that give you kind of, in the old days, and we haven't used it unless we're doing a trial. We stopped using the ruler. I mean, in my training, we use ruler in every single case. Yeah. I don't think we use it anymore, but this way can give you a way to
ballpark. Good ballpark.
Correct. So anyway, so we end up doing a CSI in the upper lesion, in the lower. We did a balloon angioplasty with the 740 balloon. Then we used the impact DCB, and Don't ask me why we did the 6.0, not the 7.0. I don't remember why, but we did the 6.0 DCB instead of the 7.0 DCB, even though we pre-dilated with a 7.0 balloon. And we had a less than 20% residual. And I'll show you the final result. This is pre. And we did a pullback at the end, and this is your post. Now you see nice profunda that we didn't even see before. So good result, radial axis, went home, we did not compromise it. We have limited option for this patient. If you think about it in reality, this patient has 3 options. One option is what we did. The second option is to go pedal, but the problem with the pedal, you really have no way to take pictures to figure out where you are while you're working. And 3 is sending this patient for his 3rd surgery, even though it's going to be a common femoral, but this is a very, very hostile groin that had 2 surgeries done before. So I think this is a case where the reason I'm showing it is because showing that the radial axis shows some kind of advantage here. Any comment about the case or similar cases that you've done before?
No, I think this is a great example of using radial axis yet again. And, you know, for a case like this, when you're not able to cross from above, even with that radial access, you still have the access of the pedal if it's a decent vessel to come from above, below, and then now you have your imaging available to you as well to cross. You know, there's so many ways to skin the cat, right? Like there's so many different ways to do it, but radial is a real safe way to do it, and I think that's what you showed very well, and it's a great example.
Oh, Loda, yes, Dr. Loda was kind enough to share this case with us. I reviewed the case, and it just showed what skilled interventionists really can do in those patients, and it's a really interesting case to show. And Dr. Nair, I'd love you to comment about this technology or this approach, because it's something that not a lot of operators are familiar with, and not a lot of staff is familiar with. And this is if you want to open a CLI wound management program, critical limb ischemia program, limb salvage. This is what you need to deal with. Anyway, so he went in, patient has a non-healing wound, almost basically a pre-gangrenous on the left foot, and took angiogram, which showed all the artery looks great, except the AT, it's 100% occluded. So this is the pictures. Everything all the way down looks really good. So you have a PT peroneal looks good, and you have an AT that's occluded. And if you see the AT occluded from maybe mid-segment all the way down, but if you look at the PT, you see a very nice loop that is incomplete. So he tried to do the regular pathway, and he put his wire through the AT, didn't go through, went through a dissection, he ballooned some, he can go back to a normal, the true lumen. So you have 2 options here, is to say, hey, I can do anything, sorry, lose your toe, and hopefully it heal. Or what he did, he basically used that loop to go from the PT to, you know, this all still frames. Unfortunately, we don't have any images to show how the crossing is, but he placed the foot the right way. He was able to see what the arch looks like, and he put his own 4 wire through, and basically used the 200 balloons. I think that's where those arch reconstruction therapy became available, because before we didn't have the longest balloon we had was 175. This is a 200 balloon, was able to cross through, open the arch all the way up, and now you see he connected the top and the bottom, and you have a nice flow in the AT from the top towards that toe. So Pradeep, talk to me about arch reconstruction. I know this is going to be an hour conversation, if not longer, yeah. But when would you do it? What's your technique? What's your devices? Simple.
Yeah, I mean, honestly, you know, in the past, if we needed to really revascularize this, we would probably stick antegrade, and then just, you know, you can do it that way. I think what this case example shows is that it can be done, right? And it's important to show that, because in the past we couldn't do that. And so, you know, we want to be able to do this safely and effectively. And the important points, take-home points here, is that we have devices long enough to cross from the posterior tibial artery through the lateral plantar into the dorsalis, up the anterior tibial, And most importantly, we now have a balloon that is long enough, the Sublime balloon that's 18,000 or 14,250 cm, you know, that can go around the pedal loop pretty effectively on an RX platform. So you could have your workhorse wire around and have a little bit of wire hanging out, and you can still get your balloon through. And that's a big game changer for us. We have crossing catheters now that can do this. So I think, you know, are we 100% there? I'm going to be honest. No, right? Let's be honest about it. No, because sometimes you need stents. Sometimes you need to do some adjunctive atherectomy that you can't reach into that direction. That's where pre-planning comes into play. But this case shows that we're headed in that direction. We're very swiftly moving in that direction. And it's exciting to see, because I think the future is bright for radial to peripheral interventions across the board.
If any of the audience has a question, I think Kelsey can share Dr. Nair contact and my contact, and we'll be happy to answer any question and helping you guys build your own practice that in the radial to peripheral if we can anyway. And Kelsey, thank you so much for setting this one up.
Yeah, thank you all for attending and spending your night with us. Appreciate it.
It was a pleasure being with you.
Have a good night.
Later.
Take care.
Bye-bye.